Greetings, everyone. Yes, let me first get everything organized. Right. So, uh, today we have a very interesting session. And I want you to first think of who was the very first person you met today at work? If I asked you that, what comes to your mind? Is it a name, a face, maybe a smile of recognition, a greeting, or a conversation? These are the things that shape how we see and remember each other. The things that make us what we are, at least to the outside world. But what happens when disease or trauma affects the face? The impact is profound. In a single moment, a person can lose not just physical form and function, but also confidence, social connection, and a very important part of their identity. As dentists, we have the extraordinary privilege of helping restore what has been lost, not just function like eating and speaking, but also the ability to be seen and recognized. Most of us are familiar with prosthodontics in dental practice, but today we go deeper into the remarkable world of oral and maxillofacial prosthodontics and how modern advances are expanding what is possible. Welcome everyone to this Tuesday's live stream of the Dentistry special series on Oral Pathology 360, where we look at diseases and their management with a holistic 360-degree view. I'm Dr. Mandan O'Donoghue, your host for the live stream and the founder director of Oral Pathology 360. But before we dive in, just a quick note. Our channel membership is open and it comes with some great perks, including certificates for attending live streams like today's, access to exclusive content, and more. To join, you got to just click on the join button below the video, choose the category you want, and join. Now, why is this necessary? Well, it helps us to continue creating high quality educational content that remains freely accessible to all. Now, if you are a member and attending the session, all you got to do to get your certificate is, well, attend the live stream and then interact in the live chat and fill the form for this, the feedback form, and the link is given in a channel post that you will see. It would have probably also come to your email. You got to fill this up within 24 hours. And we'd also like to give a warm welcome to everyone who's joined us recently. We are so glad to have you with us. Now, let's get to the session we all have been waiting for. And let me bring, yes. So, it is my pleasure to welcome Dr. Sunanta S., Associate Professor at VMS Dental College, a gold medalist in prosthodontics with 2 decades of experience. Dr. Sunanta brings a rare blend of clinical skill, academic insight, and a deep passion for craniofacial rehabilitation. And I must say, I have been looking for someone to do this topic for the last 4 years. So I'm really very glad to find her. And let's welcome her. Yes, welcome, Dr. Suranta. Lovely to have you with us.
Thank you, ma'am. Thank you for having me here for enlightening about the craniofacial prosthodontics. Thank you for having me here, ma'am. So
You're
I
most
think
welcome.
this session would give, yeah, I hope
Yes,
this session would bring about some kind of awareness about craniofacial prosthodontics among the dentist as well as the audience, whoever is watching.
yes, absolutely. That's what we hope. So, with that, let's just go watch the lecture and then come back and you can ask all your questions.
A very warm welcome and good evening, everybody who's present here for this webinar today. I'm delighted to have you all with us for this webinar on refining faces, restoring life, a journey into a craniofacial prosthodontics. Before we begin, I would like to extend my gratitude to Oral Pathology 360 and Dr. Mandana ma'am for giving me an opportunity to present in this podium. So I'm Dr. Sunanta. I'm working as an associate professor from the Department of Prosthodontics from Vinayaga Mission Shankaracharya Dental College, Salem, Tamil Nadu. The craniofacial prosthodontics is a highly specialized and a transformative field within dentistry that bridges the gap between function, aesthetic, and restoration of the human dignity. This branch not only addresses the complex craniofacial defects that arises from trauma, cancer, or the congenital anomalies, but it also demands on a deep understanding of anatomy, biomaterial, digital technology, and above all the compassion. So today's session is an unique opportunity to delve into the art and science of facial rehabilitation and explore the latest advances and to learn how to make a difference in patients' life. So I hope this session will enlighten your perspective and inspire innovation in your own clinical practice. As per the glossary of prosthodontic terminology, the maxillofacial prosthodontia is an art and science of functional or the cosmetic reconstruction by means of non-living substitutes for those regions in the maxilla, mandible and the face that are missing or the defective area because of surgical intervention, trauma, pathology or the developmental or the congenital malformation. The objectives of the maxillofacial prosthodontics is to restore the aesthetics and the cosmetic appearance of the patient, to restore the form and function, to protect the existing tissue. It acts as a healing of the existing tissue. The more important factor is that it improves the psychological well-being of the patient. The maxillofacial defects could be congenital, that is at the time of birth, or it could be a developmental defects, which means during the time of growth, or it could be an acquired defect that is caused due to any trauma or due to any underlying pathology. The maxillofacial defects could be an intraoral or an extraoral defect. If it is intraoral, it could be an hard palate or a soft palate or a mandibular defect and a combination of these. If it is an extraoral defect, it could be a cranial or the facial defects which might involve ear, eye, nose and a combination of these. So based on the defects, the prosthesis has to be given. So if the prosthesis is given during the time of surgery, it is called as a surgical prosthesis. If it is given as an interim or a periodic time or a temporary period, it is called as the interim prosthesis. And the final one is called as a definitive prosthesis, which remains for their entire life. Now let's begin this case series with the congenital defects. Cleft palate is a kind of a congenital defect. This baby is just 18 months old who walked into the department with a cleft in the hard palate. So we decided to give an appliance called as a feeding appliance. So we went again and did a rubber base impression and the feeding appliance has been fabricated. This particular appliance helps to avoid any kind of regurgitation during the time of feeding, and also it helps to avoid any speech discrepancy during the type of growing phase. So this particular baby is having a congenital heart disease, so surgical closure of the palate was not possible at this age because of his physical condition. So that's why we had given a feeding appliance to this baby. The next congenital defect is a cleft palate involving the lips and the nostrils. Here is a baby who is just 3 days old who's been referred by a pediatrician to our department. So here we plan for a pre-surgical nasoalveolar molding. The pre-surgical nasoalveolar molding appliance is an orthopedic appliance which is a non-surgical method of reshaping alveolus, lips and the nostrils before surgery and lessening the severity of the cleft and thereby reducing the scarring. So it is a passive method of bringing the alveolus and the lip together by redirecting the force of natural growth. As a first step of PNAM appliance, the primary impression is made. The most critical aspect of an impression making in such a small infant is the aspiration. So the positioning of the baby is very much critical. So we used a rubber based material to make the impression. Primary impression is made, cast is fabricated, and the special tray is fabricated. Once the secondary impression has been made, the master cast has been fabricated, and any kind of undercuts or any sharp areas has been blocked out with using a modeling bags, and the appliance with a retentive button facing downwards at 45 degree to the occlusal plane is fabricated. When the appliance is ready, the modeling can be done by directing the greater alveolar segment inwards by adding the soft liner to the inner surface of the labial aspect, while here in this blue color region by adding a soft liner, and reducing the acrylic portion in the palatal surface of the appliance, that is the red region, thereby redirecting the greater alveolar segment and the lesser alveolar segment so that the cleft opening is reduced. This is the appliance which is held in the patient's mouth by orthodontic tapes, retentive tapes, and the elastics, which gives an activation force of about 100 grams. So this appliance is inserted and the retentive tapes are secured extraorally. You will be able to appreciate that the appliance in the second week, which had a gap of about 13 of cleft, slowly by doing the nasoalveolar molding, the cleft size has reduced of about 8 at the 8th week. This is a pre and post op pics. This is taken at the day 3 and this is taken after the surgery, that is 5 months. You will be able to appreciate that the scarring is very much reduced, and the width of the cleft is also been reduced by using a PNAM appliance. This is another similar case of unilateral cleft with involving the lip, and the nostrils has been collapsed. So in order to enhance the aesthetic of the ala of the nose, we have introduced a nasal stent. So when the cleft gap reduces to 5 to 6 a nasal stent can be added to the appliance to mold the active nasal cartilage to give a proper shape to the dome of the nose. This is another case of 6 days old male child which had a bilateral cleft with the anteriorly placed premaxillary region. So again we have planned for a PNAM appliance. As a routine procedure, primary and the secondary impressions were made, mastercast has been fabricated, and this is the PNAM appliance which has been fabricated. This appliance is different from the previous one where you can appreciate two studs here, and the area which has been marked in blue are the two wings of the palate, and that's the area where you have to add the soft liner, and the area which has been marked in red are the area where you have to reduce the around 1 to 1.5. So this is the appliance in place. Now let's move on to the acquired defects. The acquired defects could be caused due to trauma or due to any kind of underlying pathology. So it could be in the maxillary defect or it could be a mandibular defect. If the acquired defects exist in the maxilla, we give them a special appliance called as an obturator. So this obturator is a prosthesis which is used to close any openings in the hard palate and the alveolar structures. This obturator could be a surgical obturator, interim obturator, and a definitive obturator. The main role of an obturator is to restore the palatal form, aids in breathing, and enhances the speech, swallowing, and supports the oral prosthesis. The obturator is classified based on the phase of treatment. It could be a surgical obturator, interim, or the definitive obturator. A surgical obturator can be an immediate surgical obturator or a delayed surgical obturator, which means when during the time of surgery, if the obturator is given, then it is called as an immediate surgical obturator. After surgery, within a period of 10 days, if the obturator is given, then it is called as a delayed surgical obturator. This is a case of a surgical obturator. This is a pre-op pic which shows the complete dentition. Here the surgeon discusses with the prosthodontist the area which is to be excised during surgery. And this is the cast which is fabricated, and the surgical obturator is fabricated, and it is in place during the time of surgery. So this particular obturator not only helps to close the opening but also aids to retain the surgical packs or any kind of healing aids during the time of surgery. Now let's move on to the next type of obturator, the interim obturator. This is the preoperative picture which shows a hemimaxillectomy done for the patient, and the surgical phase and the healing phase is over. Now the patient has resumed his normal life. So before he could go and communicate with the social network, he wants to restore his facial aesthetics and the speech phonetics. So we have given him a regular acrylic denture with an obturator, and this had improved his psychological well-being and his speech and the masticatory efficiency. This is another case of an interim obturator which is supported with the clasps. This is a type of an obturator where you will be able to appreciate that the maxilla is completely removed and there is a direct communication with the inferior concha of the nose and the oral cavity. So we went ahead and did the primary and the secondary impression. Jaw relation has been done. Because the defect is very big, the denture which is fabricated will also be heavy. So in order to reduce the heaviness, the inner surface or the palatal area of the denture is being thinned down, and we have given an hollow bulb or the hollow denture in the palatal region. You can see the denture which is floating in water, which gives an evidence that there is a buoyancy in the denture and light weighted. So now it is been inserted in the patient's mouth. So if the denture is too heavy, the denture may not be retentive in the patient. So we have used the existing undercuts in the patient's mouth and the denture has been in place. This is a special kind of an obturator called as a two-piece obturator. This patient is a medically compromised patient, a HIV patient. He has undergone a hemimaxillectomy done with a huge defective area. This defective area had a direct communication from the intraoral to the external surface through skin opening, and we were unable to make an impression and give him a prosthesis as one single piece. So we decided and fabricated a two-piece prosthesis. So one piece goes into the defective area, so this is an obturator, and the second piece is a regular denture with an hollow region in the denture. So both the obturator and the denture were made hollow in order to reduce the weight of the denture. This is a video of a patient who had received an obturator. So this particular video is a pre-operative video which you will be able to appreciate the more of a air or the nostril sound, and the wordings are not very clear.
இங்கே எதுக்காக வந்தீங்க? எங்கே எங்கேருந்து அனுப்பிச்சி விட்டாங்க? இங்கே ஜிஹெச்லேருந்து அனுப்பிச்சி விட்டாங்களா? சரி.
Now I'll be playing the same patient with the same set of words said after the obturator is in place. You will be able to understand the wordings, the pronunciation has been improved, and the patient is very happy with the way he speaks, because his main complaint was that none of them were able to understand what he speaks. Now after placing the obturator, even the consonant sounds like S were very clear. So the patient was very happy with this obturator.
சொல்லுங்க.
என் பேர் செல்வராஜி, ஆத்தூர்லேருந்து வரேங்க. பல்லு கட்டுறதுக்கோசரம் வந்து ஜிஹெச்சிலிருந்து அனுப்பிச்சிருக்காங்க.
என்ன தொழில் பண்ணுறீங்கய்யா?
விவசாயம் பண்ணுறோம்.
எந்த ஊர்லேருந்து வரீங்க?
ஆத்தூர்
சரி சரி சரி. எந்த ஜிஹெச்லேருந்து அனுப்புனாங்க?
சேலம் ஜிபி.
சேலம் ஜிஹெச்லேருந்து
ஆ.
அனுப்புனாங்களா? சரி.
The next kind of obturator is a definitive obturator. So when the patient has surgery is over, when the healing phase is over, when the patient is given an interim prosthesis, he gets used of the appearance and the mastication and the occlusion. And now once the patient is accustomed with all the interim prosthesis, then if the disease is not progressed and there is no recurrence of a disease, we go ahead and do the definitive obturator. So this is usually done with the help of cast partial denture. So here the cast partial denture is fabricated along with the obturator, and it is inserted in the patient's mouth. Here this is a second kind of an definitive prosthesis where you can see an hemimaxillectomy with a huge defect having an extraoral communication. So this is a definitive obturator. So we went ahead and made the primary impression. Cast partial denture has been fabricated. This particular obturator is called as a hollow bulb obturator. So this is fabricated in 3 steps. First, the cast partial denture has been fabricated, and then the second step is fabricating the bulb or the obturator area. So here we have used a putty material and made an impression, and using that impression we made two parts. We will not be able to fabricate as a single part, so we cut the rubber base and flasked it, and this is a little tedious procedure where we have trimmed the complete acrylic portion and made it as an acrylic shell, and we have closed it with an acrylic self cure. So it is a complete hollow bulb obturator. The third step is the fabrication of the maxillary or the extraoral prosthesis. Here, once the obturator is in place, there is a fullness which is created, and now there is a distinct boundary of an extraoral defect is seen. Now we have made a facial moulage, and the cast is fabricated, wax pattern is fabricated, tried in the patient's face. This is a silicone material which is used, and color matching is done, and the final extraoral prosthesis is in place. Here the patient has undergone a complete maxillectomy. So we have fabricated an obturator along with the complete denture, but the retention of this particular denture is really compromised, and we were not able to use the existing undercuts. So we needed an additional retentive aid. So we are using the orthodontic headgears as a retentive aid. A retention of an obturator is very crucial for the success of a prosthesis. So it is based on the dimension of the defect area, the height and the width of the defect area. Here is the patient who has reported with us, and the retention of the obturator was little compromised because it is surrounded by so much of soft tissues. So here we have planned for a basal implant supported obturator. So the patient has received 6 implants, 3 in the anterior region with the support of the nasal bone, and 2 with the support of the pterygoid region, and 1 in the support of the sinus wall. So with the help of these basal implants, the prosthesis was retained. After seeing an array of cases, mandibular maxillary cases, let's move on to the prosthetic rehabilitation of a mandibular defect. This is a case which reported to the clinic which had an hemimandibulectomy done, and there is a deviation of the mandible when the patient opens and closes his mouth. So this deviation is because of the muscle pull in the affected region. A mandibular guide flange prosthesis is a dental appliance designed to help the patients who have undergone hemimandibulectomy. This prosthesis helps to guide the remaining jawbone back into its correct position, improves the speech, chewing, and the overall function. It's particularly useful when there is a deviation of jawbone due to muscle pull after the surgery. So it is always advised for to do or to give the mandibular guide flange immediately after the surgery within 10 days, thereby it reduces the muscle pull. So this particular case, I would like to acknowledge the contemporary clinical dentistry article done by Nair S.J. et al. Now let's dive into the next part of the webinar, the extraoral prosthesis. The extraoral defects can be rehabilitated with help of many materials. One of them are the acrylic resins. This acrylic resins can be used in the areas where there is a little movement and intrinsic and extrinsic shining can be done. But the main disadvantage is its rigidity and the exact lifelike appearance may not be possible in an acrylic resin. In order to overcome the disadvantage of an acrylic resin, there comes a material called as silicones. It is a polydimethyl material. This material can be strengthened by using fillers. By adding colors, it can improve the colorations, the required color. So it exists in two forms. One is the heat activated or heat vulcanizing silicones and the room temperature vulcanizing silicones. The main advantage of the silicone is it gives a more lifelike appearance. This is a case of a developmental defect where the patient has a bilateral missing ears. So rehabilitating a bilateral missing ears is quite simpler than an unilateral ear because you can always take an impression or duplicate the ear of his siblings or their parents. So impressions were made and it has been wax trained, and this is the dewaxed model, and the silicone is shade matched, and this is the final prosthesis. This is a unilateral missing ear patient. Fabricating this ear is little tricky because we have to exactly match the contralateral or the normal ear's shape and size. So the wax up is done, carving is done, checked, wax train is done, checked for its angulation positioning with the normal ear, and then it has been flasked as a three-part mold. After the color matching is done, the silicone is packed in the mold space, and this is the final prosthesis. Now the prosthesis is in place. The next extraoral prosthesis which we are going to see is an orbital prosthesis. This is a patient who had reported with a defective cornea. This is lost due to some accident, and we have made an impression using a rubber based material, and the cast is fabricated, and we have made a wax pattern, and this is the acrylic shell which has been fabricated. The most important part of a face is the eye. So here we have done an iris pattern which mimics the exact normal eye in its size, shape and color, and it is checked for its accuracy, and the interpupillary distance were also verified. Once it is done, the flasking is done, and this is the final orbital prosthesis, and the orbital prosthesis in place. This is the most recent case which we have done just 15 days back. This is an ocular prosthesis, a combination defect of ocular as well as the maxillary defect. So this patient is a very young patient, just 35 to 40 years old, and because of mucormycosis during COVID time, He had to lose his a part of an eye and the maxilla, and even the part of his frontal bone has been scrapped off. Here again we have done the treatment in two phases. First we have completed the intraoral rehabilitation by giving an obturator. This is the wax pattern of the obturator. Once the final prosthesis has been delivered to the patient, then we went ahead and fabricated the ocular prosthesis. So this is the ocular wax pattern trying. So during the time of wax pattern, we have checked for the positioning of the eye, the iris, as well as the periocular region. So once it is satisfies the patient, then we went ahead and packed with the silicone prosthesis. And this is the preoperative and post-op picture of an ocular prosthesis. Here is another case of an ocular prosthesis where you will be able to see this is how the impressions are made. Wax drying is done, and this is the file and silicone prosthesis. In order to replicate the eyelashes, we have placed the hair threads and we have sewed in the silicone prosthesis. In the previous case, we have placed the commercially available eyelashes. So either of the way you can mimic the eyelashes. So this patient you can appreciate a very large ocular defect which has been replaced with a ocular prosthesis. This patient walked into the clinic with a nose acrylic prosthesis. This patient was having this prosthesis for more than 12 years. So now we have to replace this prosthesis. So we have made an impression, wax pattern fabricated, and the profile and the frontal view were verified. And then the silicone prosthesis has been fabricated and delivered to the patient. The prosthodontist not only replaces any craniofacial defects but also any missing part in the body. Here is a patient who reported with the missing fingers. So we took an impression of alternate impression of a defective fingers and the normal finger, and we poured the wax in the normal impression and mirror imaged the fingers of with the normal with the defective side. Wax drying was done and the final prosthesis has been delivered to the patient. This is a very interesting case of craniofacial prosthetic reconstruction. This boy reported with a herniation in the skull vault. This has happened because the patient had a trauma and he had to remove the part of the skull vault, and because of the deficit area, there is a herniation of the brain in the traumatic in the deficit area. Or so we went ahead and made an impression, and this is the master cast, and we made a working cast in order to bring the shape of the skull vault, and we made a wax pattern. This is the final cranial prosthesis which has been fabricated. There are multiple holes given here. This is given just to maintain the intracranial pressure within the skull vault. This is the operated area, and you can see the cranial prosthesis in place, and this is the post-op radiograph and the post-op pic of the boy. This is a very recent case of mine where the patient reported to my clinic with a exposed titanium mesh, and the neurosurgeon has removed the exposed titanium mesh and he wanted a patient specific implant. So this is how the patient looked after the removal of the mesh. So we wanted to fabricate a prosthesis exclusively for the patient, and we plan for a peak kind of prosthesis which will weigh lesser. So this is a 3D virtual image of the skull of the patient. This is the 3D printed skull vault of the patient. As said previously, the peak patient specific implant was not possible because of the size of the defect. So we went ahead and did a titanium patient specific implant, and this is how it has been planned. Even the screw holes were planned and the diameters were planned according to the neurosurgeon's need. And this is how the resin pattern, this is a 3D printed resin pattern, and it has been tried in the patient's head for its accuracy and for the margin. Once it is approved, the 3D printed titanium patient specific implants were done. This is the titanium patient specific implant placed in the cranium during the time of surgery, and this is the immediate post-op of the patient specific implant. You can see that the contour of the vault has been restored very well. In the previous slides, we have discussed various extraoral processes like eye, ear, nose, and fingers, and cranium, etc. But retention of these extraoral processes in place is the crucial factor. Different type of adhesive materials can be used for the retention of an extraoral processes. In this case, a double-sided tape is used to retain the nose prosthesis. Here, the adhesive liquid or like a bonding agent is used as a adhesive agent to retain the ocular prosthesis. This is a now it is a water soluble, water based material, so the patient can easily remove it by himself and place it by himself. Any anatomical undercuts, or in case of ocular, nose, or the ear prosthesis, the spectacles can be used as a mechanical retentive aid. Additional retention can be obtained with the help of a magnet retained prosthesis. Here is a case where the magnet helps in the retention of an ear prosthesis. Whether it is an intraoral prosthesis or an extraoral prosthesis, an implant plays a fantastic role in retaining a prosthesis. Here, the three implants are placed in the mastoid region, and it is connected with a bar, and the ear prosthesis has a clip in it. So using a bar and clip attachment, the prosthesis is retained. So this is the final prosthesis. The recent advancement in the modeling of extraoral defects is by doing a 3D anatomical data using a scanning technique like CT scanning, MRI scanning, or a 3D optical scanning, and now the facial scanning is also available. And with the help of this, a 3D computed model or a blueprint of an extraoral defect can be fabricated. The recent advancement of fabricating an extraoral and the intraoral processes are the CAD/CAM technology and rapid prototyping. The more recent advancement is that the 3D bioprinting. So this is a form of 3D printing that uses a living cells and the biomaterials to create a structure that mimics the biological tissue and the organ. So this technology is used to involve the depositing cells and biomaterials layer by layer to build up a complex 3D structures. So this will be the future of an extraoral prosthesis. As we come to the end of this webinar on craniofacial prosthodontics, I would like to say that except one case, all the cases were done by me and my colleagues. The COVID-19 period, we had to rehabilitate many mucormycosis affected patients, and though it might be a challenging phase, it paved a way to explore various types and techniques to rehabilitate them. So this profound role played by the dentist or the specialist in restoring not only the face but also their life. So I would like to conclude from trauma to the congenital anomaly, from cancer rehabilitation. Our work blends art, science, and empathy to bring function and dignity back to our patients. Hope today's knowledge sharing inspires us to innovate, to collaborate, and to evaluate the standard of care we provide to our patients. So I now like to thank you all for being a part of this webinar towards the excellence in craniofacial rehabilitation, and thank Oral 360 for giving me an opportunity to share my experience with the viewers. Thank you. These are my references.
Thank you. That
Hello, ma'am.
was I think, one of the most fascinating lectures we have had on the channel. Uh,
Thank you.
it's amazing. It is so interesting that so much is possible. Um, so I'm going to ask everyone, as usual, please put in your questions at the side. And in the meanwhile, let me just give you all these two bits of information. Now, of course, fascinating as managing cases are, taking them to the end stage and maybe processes, uh, diagnosis is equally important, and the right diagnosis. It starts from the right biopsy. So, on September 13th, we are hosting a live online masterclass on biopsy techniques in oral and maxillofacial diagnosis. The session is going to be a practical, highly visual, and focused on the real world skills every clinician needs. There are video demonstrations of actual cases and everything that you need to know, really, about right from case selection to what are the common pitfalls, where you should not perform certain type of biopsies. Everything is covered. If you are a general dentist, a postgraduate, or an early career specialist, or maybe an intern, this really is something you don't want to miss. And registration is open with a discounted fee right now. You will find the link on the homepage of our website, which is www.oralpathology360.com. It's also on the description of this video. It's really not difficult. It's there everywhere, actually, on all our channels. So do go ahead, have a look at it, share it with your colleagues and others that you know who may be interested. And of course, another quick reminder, if you're already looking ahead to our next year's big event, the IODCPC 2026 will be held from 8th to 10th of May, and we are starting to build something even bigger and better than last year. Now, if you would like to be among the first to get updates and special discounts, just sign up for our early information list, where once in 2 3 weeks you will get an update about who are the speakers, what is happening, what we are doing, and eventually you will get a chance to register at below even the early bird prices for a week before we actually the registration goes live. So go right ahead and register yourself for that. Again, the link to that is in the description. So with that, let's come back here and see what is happening. Let's go to our discussion page. Yes. Okay. Now, I found this so very fascinating. I think I'm going to start from the end. With
Oh,
bioprinting becoming available, uh, is the definition of prosthodontics going to have to change?
yeah, that's right, ma'am. But it is again
It's,
a non-living substitute, yes. But it's
it's
right
an
now in a
interesting thought. I mean,
laboratory.
yeah, yeah.
It's just
It's living
uh,
substance in a way, but
laboratory.
created in a lab.
Yeah. Right now it is in just a crawling phase. It's not yet into the market, ma'am. So yeah, there are some of the bio inks produced in the field, and they are slowly trying with few other materials. Yet not yet come to the market.
Yeah, it's very fascinating. I will leave you prosthodontists to decide about what is going to be the ramifications of having biological tissues. But coming back to what we were discussing, even a little earlier before we started, we were discussing. Uh, you were telling me that cost is a major factor.
Yes,
So,
yes, yes.
how much does it cost one of these, any of these,
Uh,
as a sample?
Ma'am, it ranges. There's a huge range. You can't specifically say in
Oh,
case if the last case, if you could see the titanium cranial vault, uh,
yeah,
the charge itself, because we had to do a titanium and it's pretty expensive. That particular vault cost around 1.5 lakhs. The 3D printing,
yeah,
the laboratory. I'm talking about only the laboratory cost. So
correct.
after that is the surgery and all other stuffs. So because now few other materials called as peak have also come. If the defect is very small, we can go ahead and go for a peak kind of material. It is not a metal, and it has. The weight of the material is very less, but you can't fabricate for a very bigger uh, defect. So again, that is double the time expense of a titanium. And very
True.
few labs in India only fabricates that peak,
Mm.
because
I think
it's
even
a milling.
fabricating
Milling.
titanium may be difficult.
Yeah, they have laser printing is done in case of titanium. So in this particular case, it was a laser printing, not a milling. But if I had to do peak material, it has to be milled off. So there's a difference.
Okay.
So you can't mill such a big peak. Peak is
True. True.
it's a new kind of material where many of uh, implant crowns are fabricated with peak.
Right. Now I understand that there are actually very few institutions within India who are doing this
Yeah.
sort of work.
Yes.
So, in that case, have you thought of or can you provide this service to people from other places, maybe collaborating with the local dentist or whatever?
Yes, can be done, ma'am.
Can be done.
We have
That's good.
around 15 postgraduates, and we actually uh, educate the ophthalmologist to direct their patients, and we have our own medical college, and also we visit the pediatric department to send this cleft lip pallets, and the GH close by the near town GHs. They actually send their patients here.
Yes. Another thing I wanted to ask, and forgive my total ignorance in this, what happened? I mean, now we know dentures have to be removed every night.
Yes,
Okay.
yes, ma'am.
So, what happens with these obturators? Are they supposed to remain in place? Are they supposed to be removed and
They
cleaned
have to
every
be.
day?
They have to. They has to be. It has to be removed, ma'am. It has to be removed. Even the extraoral prosthesis, the silicone prosthesis which we give, like eye and ear, that also has to be removed periodically. And the main problem is that the adhesive whichever we use, so it's like we have to apply the adhesive, the patient has to apply the adhesive and stick the eye or ear, and nowadays it's water soluble and he can take it out and just clean it with the regular running water. Previously it was like we had to give them resin, the adhesive remover. Currently, it
Okay.
has refined as a water soluble adhesives. With the help of that implant retentive processes, these adhesives can be avoided. It's all an extra oral implants. It's not the same implant which we use intraorally.
Correct. But even when we use, so often we're using, like you mentioned, is undercuts that are used for retention.
Mhm. Yes, ma'am.
So, in which case, how difficult does it become for the patient to take it off and put it back?
We actually don't involve all the existing undercut. We cannot right and left. If there are two undercuts, we don't use it. We use only one undercut, a favorable undercut, so that the patient can remove it and place it in that particular path of insertion. You cannot give whatever. So even if we are able to record the complete defect, we might have to actually close or block out few of the undercuts where during the impression itself some of the patient might bleed. So we will know which undercut is very traumatic, and we used to close the undercuts if it is traumatized, or the one which I showed previously with the nasal concha. The patient was bleeding
Correct.
when we took the impression, so we had to close the undercuts. So it's the
Now,
main
what about
challenge is
this?
not fabricating the process.
Yeah,
Yes, ma'am.
exactly. That's what I was just thinking. So, in which case, even the taking the impression itself is very challenging. Do you
That's
need
the
to
main
do
challenge.
this under any sort of a medical supervision, or is it okay for you to do it in the clinic itself?
Yes, it is okay to do it in the clinic. Only thing you have to be aware of how you have to take the impression, and if there is any opening, I might have to block out before even I keep my impression material. And
Right.
it has to be. It is not like a normal impression. So there is a technique for taking an impression. We might have to periodically remove and keep it so that it doesn't go and stick into the undercut.
Exactly. Yes. So this is, uh,
It
it's an
the
amazing thing.
procedure might look very simple, but it is all tedious procedure.
Oh no, and I have to speak for myself. Nothing in prosthetics looks simple to me. I had a hell of a time with plain simple dentures. So absolutely nothing in prosthetics looks simple to me. And maybe why I'm not a prosthodontist. So uh, yeah, no, this has been really very educational, and it is, I think, something we really need to get uh, others besides prosthodontists to know what is possible. People in the diagnosis and the treatment side need to know what is next and what is possible next. They
Yes.
really need to do that.
So
Yes.
I would even suggest before the surgeon goes ahead and do the surgery, if you could consult a prosthodontist, he will give an opinion how to go about. So we also make a stent before they even go to surgery. That this is how we have to remove. So now the 3D stents are also available. So we place the stent and only the surgery is done, so that the rehabilitation part will be better.
Okay. That's very interesting. Yes. The only other thing now I want to ask you, I happily, today there were not much questions, so I have happily covered my own doubts, which rarely I ever get this chance, but this was a good opportunity. So, as far as the cleft lip, and or rather mainly the cleft palate goes, we of course have direct surgical treatment for those
Actually, there
without
is a
the
rule of 10.
prosthesis.
Yes, yes, ma'am. There's always a rule of
Yeah,
10 because usually those
correct,
kids are underweight. They are only two
correct.
kgs, 2.5 kgs. So they have to attain about minimum of 6 kgs, 6 months, or previously it was 10 kgs, 10 months period. So
Hmm.
until then they
That
have
was
to
it.
have feeding appliance. So we have
Okay,
incorporated a feeding appliance along with a molding. So just feeding appliance is not going to help. So this molding
hmm.
will actually enhance the closure. So
Correct,
only after 3 months the surgery could be done. So so
correct.
we always suggest how earlier, if it is even a 1 day or 2 day baby, it is better to go ahead and start the process, because when the baby is crosses 3 months, it's very difficult for us to give an prosthesis because the baby will try to pull it off.
Correct.
As I
Okay.
told you, this is an orthopedic appliance, so there will be some force exerting during the movement. So, 1 month baby will be like sleeping always, so it won't be a problem.
Still,
So
that is
that's
another thing
the
I can't imagine. Taking an impression in a newborn baby, my God. Okay. But these are
To
all
receive
things
the
that I
picture,
know are
I've
necessary.
used a spoon, just a regular spoon I've used to take an impression, not a material. Instead of a tray, I've used a spoon.
Yes. Amazing, amazing work. And it's really good to know that whatever defects are created, whether from trauma or treatment or even defects that may be developmental, there's so much that we can do, that prosthodontists can do, and of course dentists can have a hand in
Yes,
identifying and guiding the patients to the prosthodontist. So that's
true,
where we
true.
come in. Yes. It's been amazing, and I can see that I think it was so thorough, and also the fact that everyone is just taking it in, and they've probably been rather fascinated by it all. Yes, I can see that there are people who are saying that. So let's just move on to uh, yes, your little certificate, and to say
Yeah,
thank
thank
you
you.
to you.
Thank you
Thank
so
you
much
so much.
for this opportunity. Thank you.
Thank you.
It's
Oh, I can see. I
really
think
great.
there is a question there for you. Yeah. Okay. Uh, all right. Let's bring it and show it here. Okay. Dr. Sutaria has asked if cleft palate is there at age 27, surgery done 20 years ago, is consent is her. Okay. Is her
Lateral
lateral
incisors.
incisor is smaller in size compared to other side? Can we do veneer on it, or we do cleft palate close up first?
Uh, Actually, the cleft palate has to be closed by now because the patient is already 27. I don't know how she's speaking. The speech will be totally hampered. So, actually, going for a surgery is the first line of treatment, and the smaller incisor is just an aesthetic part, so that could be done later also. So I suggest to go for a cleft palate surgery initially, and then go ahead with the, because we are not aware if that particular tooth will be removed or not. So it has to go for a surgery initially, close the cleft, so that will aid in better. She has to, because the age is 27, she has to go for speech therapy initially, and then only the other aesthetic part will come into play.
Very true. Yes. Thank you. Good question. And yes. I guess it must be very rare nowadays to see someone with a cleft palate at that age.
I think
Uh,
he said that 20 years ago the cleft is already closed.
Closed,
Okay,
yes, but
if the,
then
yes, if the
something
cleft
must
is
have, yeah.
already, if it is
Hmm.
already closed,
Yes,
yes, you
you're
can
right.
go ahead and go for a, you can go ahead and go for a veneering. No, there's no issue. Only point is you have to see whether there is a debite, whether it is indicated for a veneer, and then you can go for a veneer, or you can go for a direct full coverage crown.
Yes. Good catch. Yeah, it is that it was closed. Yes. Okay, folks, we have reached the end of the session. And yeah, it is 1 minute to 7, so we should stop. Fascinating as the discussion is. And thank you so much for being with
Thank you.
us. And
Thank you, ma'am. Thank you so much.
you're most welcome. Thank you, all the audience, for staying with us. I know this was probably not in your regular set of topics, but it was very interesting, and I'm sure you have enjoyed it. Anyone who is a member, please remember to check the posts on the channel. So you will find the link, and then fill up the form by tomorrow so you can get your certificate. Right. Thank you, everybody. See you
Thank
all
you.
soon. See you in 2 weeks' time. Take care. Bye. Bye, Dr. Sonata.
Bye. Bye, ma'am. Bye.
Bye.